And there are two caveats to ablation of VF. One, there are cases where you do not necessarily need the PVC, and I'll show you two examples. And there are other cases where without the PVC, you're not going to be able to do anything. So this is a 63-year-old female, 3 weeks after cabbage. So she has ischemic cardiomyopathy, has an EF of 25%, presented with multiple ICD shock, secondary to VF. After hospitalization, she was intubated and was started on IV lidocaine amiodarone. Coronary angiography showed no evidence of bypass occlusion, so it's non-ischemic, although she has a history of ischemic cardiomyopathy, but there is no active ischemia going on. Despite medical therapy, she continued to receive between 30 to 55 external shock for VF every day. And our EP service was actually asked to turn off the defibrillator and let her die. And when we saw this, the next one too, when we saw this, we said, well, I think we can do something about this. So what do you see here? You see consistently, and this is not an exception. If you actually look carefully, this is the usual initiating mechanism of VF in any ischemic cardiomyopathy. So you see a monomorphic PVC that eventually lead to polymorphic VTVF, okay? So this is not unusual. I'll show you some paper, I think, but this is something that has been published by several groups. Our group published the first paper in 2004, at the same time with the Bordeaux group. And you can see here that the first bit is always the same monomorphic PVC. I think if we can go back. Can we go back? Can we go backward? You see that the same PVC was on the other. Anyway, let's go. Yeah, but it doesn't work. It's not working. So I want you to understand that this is not an unusual clinical manifestation. This is a rule. Okay, so this is backward. So you see that the same PVC. So here is a non-sustained episode. Here are 2-3 beats. And then, okay, forward. It's not working. Okay, there. And then eventually become, polymorphic VT and VF. Forward. Okay. So this is was supposed to be a question for you. So obviously, we were called to do this, but we consider to do this. Okay. No. Go back to the other one. This is okay. Sympathetic denervation is. This patient was under general anesthesia, so he had some sort of sympathetic, chemically induced sympathetic denervation. But sympathetic denervation is a bailout procedure that is used after you have done ablation and you think you have nothing else to offer with that. Obviously, more amiodarone, this patient has been on a very high dose of amiodarone for a while, and to the point that they decide to let her die. Surgery is not going to do anything. There is no reason to revascularize. So really, this is the best option. So next. So, and this is the things that is unique to this patient. And I'll go back. Okay, is unique to this. So one of the questions is, do you need the PVC to actually ablate this patient, or can you do a substrate-based ablation? Do you need to map the Purkinje system, or this cannot be ablated? So we already said that yes, can be ablated. And if you have the PVC, good, but in a chronic ischemic cardiomyopathy with a history of heart attack, you actually do not need the PVC. And I'll show you, okay, let's go forward. Okay, so typically what you see in this patient is the initiating PVC always have some sort of Purkinje-like potential. Go to the next one. Next. Here again, go to the next one. And this is what was happening in the lab. Keep going. Okay, here you see a better example, obviously. Go to the next. And a few more here. There is always a sort of Purkinje-like potential. Next. And so what, and this is I don't know if I have the slides on the paper. This is in the paper we published in 2004, confirmed by the Bordeaux group and then the Cook group. This is the substrate. So this is a patient with relatively small substrate, and this is the PVC mapping. So the PVC, if you can map them, they are always on the scar border, always, 100% of the time. Why is that? Because the Purkinje system survive even a transmural infarct because it's mostly an endocardial network that receive blood from the cavity. So even in the presence of a transmural infarct, you have survival of Purkinje fiber that can lead to VF storm. And if you can map the PVC, you will be able to sort of confirm that is 100% of the time they are. Here you see more lesion because in this patient along the scar, there were more area than just in the origin of the PVC where we see Purkinje light potential. So once we're there, we ablated all of them. Next. And so this is an example actually from the paper. This is a patient with an LVET where you see the PVC. Next slides. And this is the LVET, and this is where the PVC was, again, on the scar border, okay? Next slides. This is another slide from another case, again showing Purkinje potential at the origin of the PVC, and wherever they are, actually here we have a couple of different locations, wherever they are is always on the scar border as you see here. Next. And again, another example. Next. This is the initial paper published by the Bordeaux group with other center. In this paper included mostly patients with no substrate. So those are people that have an electrical storm, long QT syndrome, idiopathic VF. In this patient, you need to have the PVC. There is no way out. Without the PVC, you are not going to be successful. So the best time to bring this patient to the lab is when they're having their VF storm. Okay, next. One characteristic that you see here with the PVC, you see that the coupling interval between the distance between the Purkinje fiber and the QRS is variable. Next slides. And again, here, other example where you see the PVC with different morphology, with the different interval between the Purkinje and the ventricular activation, but they are all coming from the same area. So how is this possible? Next. Next. Another example, and sometimes you have a concealed Purkinje. So this is the firing that doesn't reach the ventricle. So it's the same here, but it doesn't reach the ventricle. So this is called concealed Purkinje firing because you record it only if you are there on the tissue. Next. So why is the reason of this variable conduction? Because the Purkinje network is very complex. So the origin can be here, but the exit point can be here, can be here, can be here. So you can have different morphology even with the same site of activation. Next. And those are some of the papers. This is the one that I told you. This is the ischemic cardiomyopathy. This is another patient. So now there are a variety of groups that reported this. Those are the one in red is from our group. Next. Next. So in ischemic cardiomyopathy, this is the paper we published. The background work actually date back to 73 and even earlier, where in experimental model, they actually show that the Purkinje tissue is able to survive a transmural infarct and is actually responsible for VF storm, even acutely. And if you can remove the Purkinje system from the model, the animal model doesn't develop VF anymore. Next. So back in 73, and then there's some more recent work again showing the same concept, that once the Purkinje network was removed from the model, then polymorphic VT was no longer be able to sustain. So we have evidence even in animal model that the Purkinje system is actually responsible in the presence of an ischemic cardiomyopathy responsible for VF storm. Next. Next. Okay, next. And this is an example from that paper. Next. So this is the paper that I show we publish, and what we have in this paper is a group of patients with the chronic ischemic cardiomyopathy that had VF storm in the absence of active ischemia. And we look at the ECG recording when we had it preceding the VF, and we saw that consistently a monomorphic PVC is responsible for initiating VF, consistently. In a group of these patients next, despite medical therapy, the VF storm, like in the patient that I showed you before, the VF storm did not settle down. Next slides. Next slides. So in a group of these 29 patients, despite medical therapy, the VF storm did not settle down, and we took this patient to the lab for a VF ablation. Next. Next. And as I told you, this is an example from the paper showing again monomorphic PVC leading to VF. Okay, it's the same monomorphic, and this is something that was seen across the board in every single case in this series. Next. So this is then from the Bordeaux group that they published a couple of months after our paper. Again, the same things. You see that you have a monomorphic PVC here that lead eventually to a VF. Next. And even in their paper, when they were able to map the PVC were located along the scar border. Next. So here you see PVC mapping and in relationship with the scar. It's always on the scar border, always, 100% of the time. I think there is one case report from Japan where it was not, and was a patient with active ischemia. If you have a stable chronic ischemia, no active ischemia, the PVC are always on the scar border. This is why in ischemic cardiomyopathy, you can do the ablation even without the PVC, because if you do a substrate map and then along the border you find this area with Purkinje potential and you ablate them and eliminate them, they will be enough to successfully take care of the patient. Next. And this is another example for the paper. Always this Purkinje potential with the PVC. Next. And again, more example. Next. Even in the setting of acute MI, this is from Cook paper, same observation, Purkinje potential preceding the PVC. Next. And here again another example. Next. And sometime the PVC, the Purkinje potential as a conceal. So you see the recording here, but it doesn't reach the ventricle. Next. So in which of the following clinical scenario the S-storm ablation can be considered in the absence of PVC? So which one do you think? So we already said ischemic cardiomyopathy, but which other of these could be an option? Okay. We all can go. Oh, they can vote? Oh, you can vote? Okay, let's vote. So, can we see the vote? 1, long, 2, so 4, short QT, no, okay. So the answer is This is fine, no? So the correct answer is Brugada syndrome. Okay, so I'll give you an example. So this is an example of Brugada. So if you have the PVC, great. But, so I'll show you a patient history. So this is a 34-year-old with intermittent Brugada pattern, history of sudden cardiac death, treated with an ICD and on quinidine. He did well for 4 years and then subsequently developed multiple ICD shock and was considered for ablation. However, no PVC were seen despite different pharmacology challenge. So this is the ECG. So what do we do in this case? We do an endocardial map where there is a very minimal scar in the outflow tract, and then we see this potential. This is the epicardium, where we see this sort of, they are not necessarily low voltage, but they are very complex with multiple components. And this is the area that we empirically ablated epicardially, and the patient has been off quinidine without further ICD shock. So this is so the only two examples where you can consider an empiric substrate-based ablation of a VF storm are chronic ischemic cardiomyopathy and Brugada syndrome. However, in Brugada syndrome, I always I advise you to look at the PVC morphology. I'll give you another example. This is the patient actually that with Brugada that I did in Dubai. So looks at this PVC morphology. This is the PVC initiating the VF, okay? Clearly, this PVC does not come from the outflow tract, right? Completely negative and is positive, negative in D3. So this PVC come from sort of the mid apical region of the right ventricle. Here I give you another example, okay? So it's completely, look at it's positive in lead 1, negative in 2, 3, positive in AVF, and then it's completely negative in the precordial lead. This is where this PVC was mapped, and this is the recording that we had, even in the absence of the PVC. So this is actually a patient that had a previous empirical epicardial ablation for Brugada, came back with VF storm. We were able to see the PVC, so we mapped them, and it was a completely different area, and nothing to do with the outflow tract. So even if in general with Brugada you can do that, and that's an option in the absence of PVC. If you have PVC, look at the morphology, because occasionally we have sort of a different situation, okay? So any question? Okay, good. So let's connect with the lab and see. I think the one that is farther earlier is Diego with Miguel. Can you connect? Okay. Diego, can you hear us? So it looks like. So from what I saw before I came here, the patient had 2 PVC morphology. One clearly was papillary muscle, and it looks like this is what they are doing with the eyes. And then there was another one that looks like was more right side. I don't know. Hello, can you hear us? Diego. Diego. They're not ready yet. Okay. So maybe there is Hector that's supposed to give a talk on substrate ablation. Where is Hector? Are you ready? Do you want to go and get? Do you want to get it? Yes. So no question about what I showed before with the VF? Sì. Yes.
When you ablate VT, monomorphic VTs in ischemic patients, do you look for His-Purkinje
No,
signal?
no, not necessarily. That's typical of the VF storm, where there is the relation with the Purkinje. Usually, when you have a monomorphic VT, right now we kind of move away from induction and mapping. We do more substrate, and then at the end we do induction to see if there is anything else. But usually, with the standard monomorphic VT, you look more for an early activation by doing the maneuver to look at the isthmus. The Purkinje potential is typical of the VF storm. And because of the physiology that I mentioned before, because the Purkinje fiber can survive even a transmural infarct. And actually, while with VT, monomorphic VT, sometimes procedure can be unsuccessful depending on how much ablation you do. With VF, if you are in the right area, is always an endocardial substrate. It's never epicardial. The Purkinje system is an endocardial. So if you look at the series reported in the literature, virtually no patient had recurrence of VF. If they have the recurrence of VT, because most of those patients have a large substrate, so if you, in fact, most of the time when we do the VF ablation, we also tend to modify the substrate for other VT. But this is the recurrence that those patients experience is only monomorphic VT, is no VF anymore, because the VF is highly successful with endocardial ablation because the Purkinje system is an endocardial network. So it's very easy to be successful with that. And there, as I mentioned, you can concentrate on the scar border. So it's exclusively for the VF, then not too much for the monomorphic VT. There are cases, obviously. You can see that sometimes with the, if you have a monomorphic VT where the papillary muscle is involved, sometimes you see some Purkinje-like potential. But to look for those potential is more important in VF storm.